Well, good afternoon, everybody, or good morning, depending on when you're watching this and in what time zone. We're here again to talk about the COVID-19 pandemic, and I'm very glad to be joined by Glenn Rall, who is the Chief Academic Officer at Fox Chase Cancer Center, the Associate Dean for Faculty Affairs at the Lewis Katz School of Medicine, and the co-author of Principles of Virology, which is now in its 5th edition. And so, Glenn, we're very glad you can join us. Want to make a quick housekeeping disclaimer right at the top. We are not, during this session, going to be announcing any changes to Temple University Health System policy. This is going to be a science-based discussion on the state of vaccines and virus research and that sort of thing. But Glenn, it's great to be together again. I had sort of pejoratively said again, because I remember a few months ago, you and I met and we started talking about what we'd be working on together post-COVID. And yet here we are again, talking about COVID-19. Can you start by just giving us an overview of where we are and what brought us to this point?
Yeah, I mean, I guess it's great to be together again. I'm kind of sad for the reason. I thought we had finished with these informational videos. I think one of the predictions that I had made at the end of the last one that we did was that, it's going to be a scary winter, a hopeful spring, and a wonderful, almost normal summer. And most of that carried out until all of a sudden August hit, and we'll talk about that a bit. And I think it has people really anxious. Anybody who's seen us, I guess, Jeremy, before knows that I kind of like metaphors, so here comes one. This feels a little bit like one of those old 1980s horror movies where you've endured the entire movie and you think it's over, but in the very last few minutes, back comes the monster or whatever for one last scare. And I thought to myself in June, July, the Delta variant was that one last scare, but actually that metaphor doesn't hold, because it's almost as if now there's a whole second movie after this, right? It feels like, oh no, we're not out of the woods yet. We've got a ways to go with this. And so I think this kind of discussion is timely, because there's a lot of people who I think calibrated how much gas they had in the tank just to get them through the vaccination into the summer. And now people, maybe we'll talk about this toward the end, people are just tired and they're weary and their fuses are short and they're angry about things and they're confused about who to trust with information and with data. And so I think things like this that are at least sincere efforts to talk about where we are scientifically have value. So
where are we?
Yeah, so your first question was, where are we with rates? So I have slides actually this time. I prepared in advance. Let me go ahead and put these up here to give an answer to that question. Okay, here we go. So this was taken, I put all of my attributions down in the lower right here. So this was literally from the Washington Post online this morning, the number of cases in the United States since the pandemic began, right? So we had the initial bump, and remember, this is where we were all completely terrified and going shopping at, Giant Wegmans at 3 o'clock in the morning and decontaminating our cans of green beans. And we had no idea what was in store back here, because this then was the winter. This is mostly January, February. Here's Thanksgiving, Christmas, and New Year's, almost remarkably perfectly timed with when these outbreaks occurred. And then we had this wonderful phase where, with this exception of this little bump that confused people for a while, where we were really on a negative trajectory. And now look where we are. So this is not just a little blip. These little things are kind of considered blips. This is a full-scale new offense that's being mounted here. And predictably, because this is not a trivial infection, the number of deaths is on the rise as well. Now, you'll note that the number of deaths is actually substantially fewer than back here. And this is not because of who's getting infected or however healthy individuals they may be. This is all thanks to medicine. Back here, we actually had no idea of how to treat COVID patients, folks that ended up in the hospital and on ventilators. Now, we have medicines, not vaccines, but medicines, things like tocilizumab, for example. We know much more about the course of this infection. And so physicians are much more able to control and treat patients. So the number of deaths is actually substantially fewer, but that doesn't mean that there are not still a large number of deaths and serious side effects resulting from it, like long COVID, for example. And what I wanted to include here too, Jeremy, is that this is just showing you the relative rates, but just 2 months ago today on June 10th, in the entire country, we had about 22,000 new cases. Today, just between yesterday and today, there are 237,000, more than tenfold more new cases. And that's just in a 2-month period of time. So that escalation is pretty terrifying, and I think justifies a conversation here. Of course, the United States is not monolithic. That is, it's not the same everywhere you go. I'm going to pick on Florida just because I kind of want to. Florida is not doing well at all. If you actually look at their 7-day average as of today, it's as high as any other time in the pandemic. This is not a great time to travel to Florida, just in terms of the number of individuals who are testing positive. Closer to home, I think we can be kind of proud of ourselves here in some way, because even though rates are increasing in Pennsylvania, it's certainly not on the scale of what's happening in Florida. And I'll point out that the y-axes here, these values here, these scales are quite different. So the number of new cases in Pennsylvania is far fewer, but still not unimportant, right? Since yesterday in Pennsylvania alone, there have been over 2,500 new cases that have been identified. And again, these are not, some of these might be short-term, fairly trivial infections. I would bet the majority of those are in vaccinated people, but there are still an appreciable number of individuals that are having really serious challenges. Again, predictably, most of them unvaccinated folks. And then I'll see what other questions you might have in a second here, Jeremy, but just to sort of talk about the flip side of this. So we talked about the caseload. In terms of vaccine coverage, the United States is doing okay. We have more people who are willing to get their vaccines. I think to some degree, the fear of Delta has compelled some people to finally relent and get their vaccines who might have been somewhat hesitant before. Pennsylvania is slightly higher than the US average, which again is good for us. Jeremy, you want to take a guess what it is in Philadelphia?
Just take a I'm going to go with a little bit higher, maybe in the 70s.
Yeah, well done. There we go. It's about 77%. I will make a qualification here that these are as a percent of total population. This is a percent of 18 and higher, that is vaccine eligible population. So this number might be a little bit lower if we're looking at total, but Philadelphia is doing a relatively good job. We are on the rise, but not the meteoric rise that other parts of the country are seeing at this point. So let me just stop sharing for a moment here. So I think that's, sort of where we are. It's our temperature check for today.
So you did a horror movie metaphor, which I really like. I always enjoy your metaphors, but I do wonder what your thoughts are. As I follow the news, I've heard the soundbite that it's a different sort of pandemic now for the vaccinated versus the unvaccinated. Is that true?
Oh, yes, right. So let's think about like any of our previous videos. In all of those cases, there was a single message for anybody, whether they were listening or not. There was a single message, right? At the beginning of the pandemic, it was distance and wear masks. And then once the vaccines became available, the message was get your vaccine. So it was the same for everyone. And now there is we kind of are stratified as a country and as a population, because the advice or how you would have a conversation with someone who's chosen not to vaccinate themselves versus somebody who's vaccinated now is quite different. Can we talk about the unvaccinated for a moment?
Sure. I was thinking you could kind of break it into two buckets. We'll talk about the unvaccinated first and then the vaccinated. Does that work?
Okay, right. So what I don't want to do, if there's anybody who's watching that isn't vaccinated, I don't want to finger wag, right? I think we've done that as a society now extensively. I cannot support getting a vaccine any more than I have. It is, as I've said in this forum before, but it warrants restating. I just turned 58. It is for certain the biggest medical advance of my entire lifetime. And I'm going to bet, even if you're substantially younger, it's the biggest event in yours as well. As I'll show you in a bit, if I have a moment, these vaccines are extraordinarily safe and effective. So if you ask my opinion, yeah, get this vaccine. But a little part of me feels, I think if the unvaccinated feel frustrated at this point, I kind of can understand that, even though I don't agree with the decision to not vaccinate yourself. When these vaccines were first made available, it was quite clear that people could choose not to vaccinate if they wanted. It was sort of like, well, do you want, beef or chicken? You get your choice. And now that people have made those decisions, now they're being told, well, you chose poorly, that you should never get the chicken, like that's the wrong choice for sure, right? And I feel like if there are people who said, well, wait, you gave me a chance to make a decision before, I've made that choice, and now they feel a little bit like they're being criticized or punished for the choice that they've made, I sympathize with that frustration. I think what's changed, however, is the emergence of this variant, which we'll talk about in a moment, and the fact that some of the initial concerns that were stated, that this is experimental, that this is a new technology, they want to wait and see. I mean, we now have had hundreds of millions in this country alone who've been vaccinated, billions in the world, and we see really no sustained negative effects other than a sore arm and maybe feeling a little lousy after your second shot. A lot of the initial justifications for not getting a vaccine have, just with time and data and more people getting vaccinated, kind of faded away. So I think the justification to not get vaccinated is on shakier ground than when we were at the beginning of this. I think what's going to happen, and clearly my predictions sometimes are completely wrong, but doesn't stop me. I think I'm going to bet that this is what's going to happen. I think the FDA is under such extraordinary pressure to approve these drugs that that's going to happen through all the right safe channels. That's going to happen in the very near future, maybe the month of August, maybe early September. And I think there are a lot of places, and I'm not just referring to universities and health systems, but restaurants and theaters and arenas who are waiting for this to become an FDA approved vaccine. And when that happens, I have a feeling that a whole lot of these different places, these venues that we want to go to, are going to say, you're welcome here, but you need to show me your vaccine card. And so it's going to make life harder for people who've chosen not to get vaccinated. You can still do what you wish, but you're going to be excluded, I think, from things that you might want to do. This happened in Paris cafes. Cafes were like, yeah, you're welcome to come in, but only if you're vaccinated. And just the threat of Parisians not being able to, get their latte compelled a whole lot of people to go ahead and get vaccinated. I have a feeling something similar might be happening down the road. So if you're not vaccinated, you might want to be cognizant of what kinds of things are going to be impacted for you down the road, especially once these are FDA approved.
Glenn, can I just do a quick follow-up to that question? Because, we're doing these for a fairly large audience. You and I in private have discuss the politics of this and the behavioral scientists, the behavioral science behind this. But as an expert virologist, as a scientist, are there really, leaving aside all the politics of it and the behavioral reasons and the economic reasons, is there any real scientific concern that you have with this vaccine right now?
No, zero, none.
Right.
None. And it's not, thanks. I mean, that's nice of you to say nice things about me, but whether I'm an expert virologist or not, other people might be like, yeah, sort of. But actually, the data is the data, right? I mean, if you have, as we'll talk about in a minute, if you have so many people who have been effectively vaccinated, and now we can actually compare, well, let's see, what are the rates of people that have landed in the hospital who've been vaccinated versus those that have landed in the hospital who aren't? It's so one-sided. It's very, very clear. I'm not, and I don't want to get into politics, and I don't want to talk about that, because I think that's been half of our problem, right? It's not that I don't have opinions personally, but in this kind of forum, that I think those sorts of conversations are inappropriate. I support whatever decision people want to make. I've commented before that we all make different decisions about our own health care. I'm kind of chubby. I've said this in a different place before, but I'm kind of chubby. And my physicians have said, hey, you may want to, lay off donuts. But if, frankly, this were live and you brought in fresh donuts, Jeremy, guess who's going to be first in line? It'll be me. So sometimes we go against advice from other people because of habit or peer pressure, and I'm not going to get involved in that. Maybe politics drives some of that. So if people choose not to get vaccinated, that's their prerogative, but they cannot use data as evidence for the reason why that would be a logical choice, in my view.
So let's turn to the vaccinated population, because I think, we're hearing, and you've just really affirmed that we're talking about almost two different pandemics for the unvaccinated and the vaccinated. But what should those who have been vaccinated be thinking about right now?
Well, they should be thinking a little bit about where they get their media from, right? Because I think there is right now such a media frenzy around the Delta virus, right? I mean, even the Washington Post referred to this as like the Goldilocks virus, and scientists trying to figure this out. I think all of us need to kind of take a deep breath, calm down a little bit, and look at this a little objectively. This is not, some crafted virus delivered, straight from hell to, to end human, the humanity. This is an absolutely predictable outcome of pandemics. It's happened in pandemics before. And guess what? In probably 6 months, nobody's going to be talking about Delta, because we're going to be talking about Lambda or Epsilon or Rho or whatever the other, Greek letter variant is circulating in that moment. So I think we have to just ratchet back our anxiety and the rhetoric among the vaccinated population, because there are a lot of folks who are like, well, why did I bother getting the vaccine if this Delta variant, if there are all these breakthrough infections and it causes just as many problems here? Let's just think about this just in as sort of non-emotional way as possible here. So these variants emerge because they replicate just a bit better than the parent. So here comes another metaphor, Jeremy. You don't know this one, but the Olympics just ended. I watched the.
Are we going to crinkle the paper again? Because I remember we talked about. Okay.
No. Do not mock me, Jeremy.
I'm not mocking you. I thought that was really helpful. With the variants.
All right.
Okay, sorry.
So no paper crinkling. No. We're going to talk about the Olympics, right? So let's say, what's the longest swimming? The longest swimming one is, I think, the ladies freestyle 1500 meters. That's 30 laps, right? So imagine if there was one swimmer. Let's just say there were two swimmers that were competing in this thing, and I even have my my measuring thing here. So let's say that one swimmer was a little bit faster than the other swimmer, and at the end of one lap, they were 1 foot ahead. Now, in the span of a lap, that's hardly anything, right? Just 1 foot ahead, a little bit of an advantage over that person, over the other person. But if that foot is sustained over the period of 30 laps, right? And we can think of those laps like replication cycles of this virus. Every single lap, it gains a foot. So at the end of this race, that variant is now 30 feet ahead, almost a full lap ahead of the other person who's now way in the dust. And this is exactly what's happening with this variant. It is able to replicate a little bit better, a little bit faster. Maybe it's a little bit stickier. We don't actually quite understand all of the things that go into what makes Delta more effective than the parent from which it's derived. But it isn't a monster virus. It just replicates a little bit better. But by doing so, over time, iteratively, you're going to actually see what has happened, which is now it dominates in terms of the human population. There really are no other variants right now. There's not a heterogeneous pool. Most people that are getting either breakthrough infections or who are unvaccinated and getting infected are getting infected with the Delta variant when those viruses are sequenced. There is some rhetoric about the virus that's out there that I don't think has actually been shown yet. There's some rhetoric, for example, that suggests that the Delta variant replicates 1,000 times better than the parent virus. That's not been proven. At least that's not been peer reviewed and published yet. That's probably based upon a very specific point in time, looking only at RNA and not necessarily measuring how much virus is produced from this thing. It certainly does replicate or grow faster. And by doing so, I think this is what has contributed to some of the breakthrough infections. So Jeremy, do you have tolerance for a couple more slides from me?
Well, I was actually just going to ask if you had any charts on this.
You know I do, because we talked we talked about this before, but yeah, it looks like it's all spontaneous. But hang on a second. Now let me get back to this. Right. Oh, all right. So just my rhetoric here about vaccines. So I actually don't like the word incredibly, and therefore the fact that I've used it twice and bolded it and highlighted it in red shows how sincere I am about this, right? 4.5 billion doses of different vaccines have been administered, Pfizer, Moderna, and the number of side effects and consequences from these things, from these vaccines, is infinitesimally small. This is across the entire planet, right? So they're incredibly safe to use. And better still, these vaccines work like a charm, right? And the reason I'm going back to vaccines is I think it's very pertinent to this Delta conversation that we were just in. So this is actually from the National Institutes of Health, that is comparing vaccinated folks, which are in blue, versus unvaccinated individuals, which are in red. So let's start over here. The things that matter to us that everyone was so scared about with COVID is not getting a cold or feeling a little flu-y for a day. I mean, that's unwelcome, but that's not the thing that had us going to Giant at 3 o'clock in the morning. It was the fear that we were going to be put on a ventilator, the fear that we were going to die. And that was a real fear pre-vaccine. Here is the relative incidence of hospitalizations and deaths in the unvaccinated compared to the vaccinated. 25-fold reduction, not 25%, a 25-fold reduction. The vast, vast majority of people who are ending up in the hospital and then dying of COVID are unvaccinated folks. Now, what's interesting is if you look over here at disease incidence, that is individuals that get infected and that might have cold-like symptoms, it's a little bit less. So these are those breakthrough infections that we've talked about, because you can see there's still a substantial reduction, but you still end up, it's not as dramatic as the hospitalizations and the death. You have an 8-fold reduction here. So there still is some degree by which the Delta virus is able to cause short-term transient illness in vaccinated individuals, but it stops there. These individuals don't progress to the serious illness and other consequences that unfortunately attend a substantial number of cases of the unvaccinated folks. And then just put a different way, these are the daily deaths by US county based upon their vaccination rate. And this is from the New York Times just earlier this month. The death rate in high vaccination counties, including Montgomery County, Philadelphia County, started off high. Here come the vaccines in May and June, and have decreased and stayed relatively low. In the case of counties with low vaccination rates, decreased because this was the rate, this was when in January, February, when rates began to dip after the awful winter that we had. And now here you're seeing the consequences of Delta, of the Delta variant, that's causing a greatly increased number of cases and deaths in these counties with low vaccination rates. So I tried to put together a little bit of a graphic here to account for why Delta is different. So beyond just the fact that it replicates a little bit better and that people are kind of anxious about it, what's different about it and how does it impact vaccinated and unvaccinated populations differently? So let's see if my little animations work here. So here we're looking at just days post-infection. So the unvaccinated panel on the left, the vaccinated group on the right, and viral load or viral level just as measured here on this y-axis. And I've drawn here just a dotted line to say that when you reach some viral level, it doesn't really work like this, but when you reach some viral level, that's when you're going to start seeing signs of illness, right? So that's this dotted line here. And we'll mark infection as, sort of day 0 for both camps here. So what happened if you got infected with the parent virus, the one to which the vaccines were initially developed? So what's that look like? So let me try and get this up. Oh dear. So in the unvaccinated folks, you end up having a certain rate of growth for this virus. So we'll call this SARS-CoV-2, the parent virus. You have a certain rate of growth. And for some of those people, but as we know, not for all of those people, not everybody ended up showing signs of illness. You hit that mark. You sort of, reached an amount of virus that triggered then triggered you to feel sick. In the vaccinated people, you might end up having a small bit of infection, but it's quickly curtailed. And the difference between these is how quickly your immunity kicks in. Vaccinated individuals, their immune responses are already trained because they've been vaccinated. So that immune response, this green box, kicks in really, really soon and can thwart or stop the parent virus from replicating so that you don't feel sick, you don't show any signs of illness, and you don't get infected. Eventually, as we know, for the folks that are unvaccinated, your immune response eventually does kick in, but it's much delayed. And that gives all of this time the opportunity for that virus to replicate and potentiate sickness in you. What's different about Delta is simply how quickly it replicates, right? So here's Delta. The slope or the pace with which Delta replicates is much, much greater. So in the unvaccinated population, this horse is out of the gate super, super fast. So we reach that illness threshold and perhaps exceed that illness threshold in terms of viral level very, very early. Now, again, of course, even in unvaccinated people, your immune response will kick in. And for the majority, one could even say the vast majority of Delta infected folks, it will eventually be curtailed. But this here is the scary part, right? Because this is where people can go into the hospital with severe COVID. This is where potentially death can occur, especially if you have other comorbidities that are going to be a complication. And we still don't quite understand how long COVID, the sort of downstream effects months after COVID, differ between Delta and the SARS-CoV-2 variant. We just don't have data for this. But what's interesting, and I think what is the basis for the breakthrough infections that people are concerned about among the vaccinated, is that rate of replication for Delta still holds true here. And you'll notice that the green bar doesn't go all the way to the y-axis. It still takes a little bit of time to wake back up the immune response, to wake back up the immune response that the vaccine generated in you. And so for some people, you can end up getting to the point where you start seeing a little bit of disease, right? This is when breakthrough cases happen where people feel cold-like symptoms, maybe feel flu-y for a day or two. But generally speaking, for the vast majority of individuals, that's rapidly curtailed by this faster immune response among the vaccinated people. And that ultimately brings this rate substantially down. So it turns out that individuals, there's a study that was done based upon data collected in Singapore that suggested that even vaccinated individuals that test positive for coronavirus, most likely the Delta strain, resolve that infection far faster than unvaccinated people do. Usually they're negative within 5 days or so post-vaccination, post-infection. So I think this might account for why we're beginning to see breakthrough infections. It has less to do with the quality of your immune response than it does with the pace by which this Delta variant is able to reproduce. All right.
So would we be getting into, I know this was a big concern earlier in the pandemic, as I was looking at those lines, at any point before illness, would somebody show a COVID positive on a test and be asymptomatic? Like
that can happen. Sure.
Okay.
In fact, there are, one of the things that I think is faded with time, but I think that's unfortunate, is testing, right? I mean, I'm about to go off for vacation, with my family and with another family. We're all getting tested before we go just to make certain. And I feel perfectly fine, but we're all getting tested because we think it's kind of prudent to be sure that nobody is showing up who's positive and asymptomatic. Because what we do know is that if you are infected with COVID, even if you are vaccinated, you can still spread it to other people. Right? And we would like to prevent that from happening. So it is very possible that, one of the 10 of us that's going away will test positive. It's a possibility. I hope not, but it's a possibility. So sure, that can happen. So
speaking of things like vacations, can we talk a little bit about like the decision-making process that people should have for when they get into situations, like what kind of questions they should ask, what's appropriate to ask your peers, that sort of thing. We're trying to live our lives. What should people be thinking about?
Right. Well, again, earlier at the beginning of the pandemic, the answer was the same for everyone, which was don't do anything. Don't go to restaurants. Don't go out. Like, kind of stay by yourself. And if you're going to have to venture out to go to the grocery store or go, wherever else, to the physician's office, for sure, wear a mask. Now, we all have to be much better with risk assessment. And you almost have to look at everything that you want to do and weigh multiple variables to make the right decision for you. And it's not like there's exactly a right decision, but depends a little bit on your risk tolerance, I think, in terms of what choice you'll make. But you might either decide, this is an event that I can go to without wearing a mask, or this is an event that I can go to, but I have to wear a mask, or yikes, this is an event that I'm going to avoid like altogether. So like, what are those variables? Well, I think where your event or where you're going matters, right? What are the local rates? And you can find this, they're available, Washington Post, New York Times, I think Fox News has one. You can find, you can track local rates down to the county. If you're going to a place where the rates are high, you might want to have added precautions. You might want to say, well, I don't think I'm going to actually go to that event. Or if I am, I'm certainly going to make sure that me and everyone else that's part of my party will be wearing masks, right? So local rates where the event is happening would be one of the variables that you have to consider. Certainly who you're going to be hanging out with, right? If you're going to go to dinner somewhere where you're vaccinated, well, okay. But what about everyone else that's at your table? What about everybody else that I'm getting to go on vacation with? Are they all vaccinated? Turns out they are. But if they weren't, that would be a bit of a cause for concern and might change some of my behaviors. And I think it's okay to ask. It's not an impolite or rude thing for you to advocate for your own welfare and say, sure, I'd like to go out to dinner with you, but I'm just checking, are you vaccinated? And then if the answer is yes, you make one set of decisions. If the answer is no, you can perhaps make a different set of choices. I think duration of exposure matters, right? I'd be much more anxious in a 1-hour car ride with someone than in a 5-hour outdoor wedding. Because in a car ride, you're sharing the same air, you're sharing the same space, versus being outside, even though it's many, many more people for a longer period of time. So in my calculation, the car ride's more scary than the wedding that you might be driving to. And I think what's very important is to think about who are the people who are part of your orbit, as it were, right? So if you're living with a grandparent, or if you yourself are immunosuppressed or immunocompromised, or somebody in your household is a cancer patient, or if you have a child who hasn't yet been afforded the opportunity to get a vaccine, something I hope turns around in the course of the next month or so, at least somewhat around when schools reopen, that might change your tolerance level as well, because even though you might be fine, there is still, as we just talked about, the potential that you would bring it to somebody else. At this point, I don't think we have to worry, and I think we'll talk in a minute here about boosters, but at this point, I don't think you have to worry too much about how long the antibody lasts, right? So like, well, when did I get my vaccine and is it starting to wear off at this point? As I'll show you in a second, I don't think yet that that's a concern, but down the road, over the course of the next year or so, at some point that might be a limitation or a barrier, and that's when we might want to think more about boosters.
Yeah, let's talk about that for a little bit, because there are actually two buckets of things I want to talk about before we wrap up with some predictions for the fall. What are your thoughts on boosters? It's another thing that keeps cropping up in the news that we may or may not need a booster shot. Pfizer's got one in development. Where are we on the booster conversation?
So there's an ethical question about them that I think is actually worth putting on the table. I'm going to kind of take it off the table in a second here, but I think it's fair to talk about that. We here in the United States, assuming that most people who are listening to this or in the US, are just so ridiculously lucky, because you could have had 2 vaccines. I mean, I hope you got them, but you've had opportunity to get a shot and then the booster shot for this. And now we're talking about layering a 3rd booster on top of that yet again. But there's whole huge parts of the world who haven't even had access to a single vaccine. And so there's some of this ethical decision, like, is it ethically right for me to, go back for thirds when there are some of my fellow humans who haven't even had their firsts. And I get that. I think, if anything, this pandemic has made us had to think really globally here. At the same time, the United States, because these vaccines have a shelf life, these vaccines are getting thrown away because they're not going into people's arms. It's not like the vaccine that you decline is going to be used to vaccinate someone in, Kenya or Laos or Sweden. So it's not really quite a quid pro quo here. And in fact, the rates of vaccination and the flavors of vaccines are increasing as time goes on as well. So certainly we'll hope that we can get everyone in the world vaccinated who wants to be as quickly as possible. In terms of whether boosters are a good idea, Israel has actually been doing an interesting study where they're giving people, because they were pretty first out of the gate with getting their population vaccinated, and now they're coming back and giving people third boosts. And what it shows is that it substantially boosts or amplifies the neutralizing antibody levels in those patients, right? So it's sort of like, taking half a tank of gas and making it a full tank of gas. Your car still would run on half a tank of gas, but it just provides added reassurance for this. I have one more slide to show you, Jeremy, just of data, but I think it's actually really relevant to this. So let me just get it on the screen here. Here we go. And let me just quickly skip right down to it. So this is from back in June, a New England Journal of Medicine study, and all it's looking at is duration of neutralizing antibodies by a particular technique called ELISA, looking at the duration of neutralizing antibodies over a period of 6 months of time. So this first arrow is the first shot. I think that this is following the Pfizer vaccine. In fact, I know it's following the Pfizer vaccine. Here's the first vaccine dose. Here's the second vaccine dose, this arrow right here, right, 29 days. And you'll note that there's a substantial bump. That's the reason why you get the second one. And so look what happens here over time. There's a slow decline. So it is slightly less 6 months out, but it's not dramatic. It's not like this thing drops off a cliff. So if you've had a vaccine within 6 months or so, it is highly likely that you were still very well protected from this. But if boosters become available, I see no downside to taking them. There have been no sort of surprise effects in individuals that have received a third shot based upon the work that's happening in Israel. And it might be able to boost your neutralizing antibody levels. I think the population, and this may be where you're headed here, Jeremy, the population that could really benefit from these boosters and who, in my opinion, should be front of line are those who are immunocompromised. For example, patients on active chemo.
Yeah, let's not talk about that yet, because I want to see because when I talk about boosters, I have a hard time separating in my head. I go for a flu shot every year. Are we eventually going to go for COVID shots every year and stop calling them boosters? I mean, isn't that effectively what's happening with a flu shot, or am I comparing apples to oranges?
You're comparing like apples to toy trucks. I mean, they're pretty different because flu is constantly mutated. No, I take that back. I just insulted you unnecessarily. It was kind of fun, but it was unnecessary. It is a little bit apples to oranges here, because influenza, the reason why you get boosted year after year is because the virus changes. It's still flu, but it mutates and it changes and it adapts. And so you have to get a flu shot for whatever the circulating strain, not variant, but the circulating strain is for that particular year. That's the reason why you get flu shots every single year. You don't get measles boosters every year. You don't get rubella or chickenpox boosters every single year, because those viruses spin off strains or mutants much more slowly. The reason why we're thinking about boosters for COVID is because it's a worldwide pandemic and rates remain very, very high. My thinking about this is probably we'll be afforded an opportunity to get a booster somewhere around the turn of the calendar year. I certainly will be getting mine. I would advise anyone to get theirs too. But once we have this pandemic under control, once it becomes endemic, that is just another circulating thing that can make us sick during particular times of year, I suspect you will not require annual boosters. But a lot of that depends upon human behavior, right? And a lot of it depends on whether we get vaccinated and we help to keep these rates suppressed and low, because even with breakthrough infections, a lot of what's fueling that, I mean, we can certainly see, as I showed in some of those graphs before, they're happening mostly in parts of the country and parts of the world, frankly, that have low vaccination rates. So changing vaccination rates will probably also dictate how frequently these boosters will need to be given.
So let's go back to the bucket that we started going into, because it's a particular interest, I think, to the internal audience here at Fox Chase, where we take care of a lot of immunocompromised patients. What are the special considerations for the immunocompromised population that people should be thinking about?
Well, what we know is that the vaccines help protect even those who have weaker immune responses, right? And you can have weaker immune responses for a variety of reasons. This is not just pertinent. I mean, I think it's because you and I both work at Fox Chase, is relevant to that patient population who are on active chemotherapy. But it's also true for the elderly, and it's also true for individuals with HIV, and it's true for people who have genetic immunological disorders. These vaccines are still good, and they're certainly better, far better than nothing. But you might, I'm not going to go back to my slide, but you might not have gotten the same level of protection or the same, sort of potency of neutralizing antibody load that someone who didn't have some immunosuppressive either disorder or condition or treatment might get. So your starting point is smaller. If I go back to my little gas tank analogy, your gas tank is a little bit less. You got gas in it, but it's going to get you less far perhaps than if you had a larger, more potent capacity. So and it's not my opinion, I think this is the general opinion, those individuals perhaps could benefit most from this in any of those categories. That's why they were front of line for the vaccines in the first place, because they were also the most vulnerable to COVID disease. But I think they're the ones that could actually benefit initially most from helping to boost up their antibody levels to as maximally as we can get them. So I wouldn't be surprised if, when these boosters become available, assuming that they do, that you're going to see some sort of phased approach as well. It's not just going to be like, they're going to open up the door and everybody goes running for their booster. We're probably going to propose or suggest that individuals who are, let's say, on active chemotherapy get front of line access.
So as we wrap up, you want to make some predictions for the fall, some thoughts for what we have as we turn to September and October? What's the fall going to look like?
Yeah, well, obviously I mispredicted August. I didn't necessarily see that coming. So I'm not sure what value this might have. So yeah, I might step out of being a little sciencey about this and talk about this a little bit more just from like a how we all interact with each other perspective. I hope that's not
sure, absolutely.
Okay. So people get frustrated, I think, with science because they're like, well, but wait, you told me that these vaccines work and now there are breakthrough cases, or you told me at the beginning of the pandemic, don't wear masks, and now you told us to wear masks. And there seems to be this frustration with science about messaging. And I think an important point to note is that one of the challenges, but one of the benefits of science is that with each passing day, we learn more. And sometimes what we learn tells us that the behaviors that we were doing before weren't exactly the right ones. And we have to modify and change our behaviors based on new information, right? Or perhaps what we were doing and advising back pre-vaccine was exactly right for then, but not relevant now. So this sort of sense of frustration about science is unnerving to me, because this is exactly how it goes. As we learn, the more we know, the smarter we are, and the better we can behave, and the better we can protect ourselves and others. I think it's fueled by a lot of things, right? As I said at the beginning, people are just tired, right? I'm tuckered out. I kind of thought this was going to be over, and I'm not ready for the second horror movie. I don't have any more screams in me, and I think that there are people who are just weary broadly, and this makes our fuses short and makes us, I I think, a little bit less discriminating about where we get our information from, right? So I've had colleagues here who send me videos of somebody, like one just was sent today, of a very well-spoken guy who was nuts. But he was extraordinarily well-spoken, and he surely was passionate. Just because you hear someone who sounds nominally bright and who is excited about what they're talking about doesn't mean what they're saying is true. And that goes for me too, right? You might be like, well, you know, maybe what makes you so certain that what you're saying is right? And it's exactly the reason why I gave attributions for every piece of data that I showed you. This is not Glenn's opinion. This is based in science. So carefully weigh where you get your information from. Just because somebody says it with gusto doesn't make it true. Rely on good old data to guide us through this. You know, and certainly politicians, and here, regardless of which side, you've got plenty of folks on both sides to pick from, but these guys are just, you know, cartoons of humans. They don't have any idea about science. So that they are actually driving policy is terribly alarming to me. It seems like you would at least want to have, you know, a bank of scientists that are advising you as opposed to making decisions based upon political fortune in one way or another. But all of this confusion and disappointment that the pandemic isn't over, you know, leads to a lot, I think, of frustration and anger. And therefore, just keeping things in perspective is really important. Vaccines are the way out. They are still working amazingly well. It is how this pandemic ends, with vaccines. And remember that the thing you were worried about back a year ago was going into the hospital and potentially dying, or worse, that your loved ones would go into the hospital and die from this thing. If you're vaccinated, that's not your concern anymore. If you get COVID, it shouldn't amp up your blood pressure the way it should have a year ago. Now it means, well, you might not feel well for a day or two, but guess what? At least based upon the majority evidence, you're going to come out of this just fine, right? So even though it might have inconvenienced your vacation, at least you're not dead. And this is what these vaccines have provided us. So just kind of keeping a sense of perspective, I think, is going to help us get through the fall. As I pointed out before, I think you're going to see FDA approval. I think you're going to see vaccinations of kids under 12. And I think all of that is going to begin to get us to a point where we don't have to have videos like these anymore.
As much as I will miss them, it's been great to be with you this afternoon, Glenn. I hope those of you who watched us all the way to the end really gained something from this. I know I did. And with that, we'll go ahead and wrap up. Thank you, Glenn, for your time and your thoughts. Thanks to the audience for listening. Thanks to everybody who's watching this for what they're doing to, you know, keep us safe through the pandemic. And we may join you again soon. But until then, take care. Thank you.
Bye, everyone.